Satyanarayan Raju is a geriatrician and a palliative care physician in Center for Palliative Care, GVP Medical College Hospital in Visakhapatnam. He had completed his MBBS from Ranganarayana Medical College, Kakinada. He had also completed his Masters in Diabetology and post-graduation in Geriatric Medicine and done the certificate course in Pain and Palliative Medicine from the TIPS, Trivandrum, India. He is a member of Sneha Sandhya Aged Care Foundation, registered charitable trust working in the areas of geriatric and palliative care, Alzheimer's and related disorders society. Visakhapatnam registered society providing support to persons with dementia and their families. Prema Samajam, society working for welfare of abandoned children and senior citizens. Andhra Vanavasi Kalyan Ashram, which is a registered society working for the welfare of tribal population. Netra Vidyalaya, GR Educational Trust, Visakhapatnam. He also holds responsibilities in Aged Care Foundation. He is a member of the Institutional Ethics Committee, Homi Baba Cancer Hospital and Research Center, Visakhapatnam. Now I request Dr. Satyanarayan Raju to come on to the stage. I would like to welcome Dr. Janakan, Head Medical Services, Athulya Home Healthcare, to welcome Dr. Raju.
Good evening. Happy to be here, to be with you. And thanks to the organizers for having me here today. I'm a social worker and a palliative care physician. In palliative care, most of the time, we don't wear the uniform. We always will be informal during our rounds and during our interaction with our patients and families. So this is the way we do our work every day. I am one of the founder trustees of Aged Care Foundation, which is a registered charity. We're just about to complete 10 years of service. I've been the managing trustee right from its inception. So our objectives are providing basic health care for elders, living in the community and also in institutions like old age homes, and people who are bedbound who do home care. We run outpatient clinics across the city, almost around 12 different locations on different days in a month. Of course, we cover a few villages outside the city and some tribal hamlets. Altogether, we almost see about 1,000 patients in outpatient clinics every month. We maintain records digitally, so all the patients go through the follow-up. But this is very basic care that we're providing. In fact, we actually provide the medicines also for 1 month. So most of our patients have some chronic diseases, diabetes, hypertension, or both, plus. We are more passionately working for palliative care because, as you know, if we don't provide geriatric care, there is always an option for them to go to some other hospital, other health facility, other clinic. But unfortunately, the access and availability of palliative care, even awareness, is very dismal. These people have nowhere to go. So again, palliative care is delivered through outpatient clinic, an institutional care, something what we call as hospice, within the premises of Geriatric Medical College, which is a teaching institution. I am not part of the Geriatric Medical College. Geriatric Medical College has provided around 2,000 SFT of space free of cost for conducting our palliative care program. The staff, doctors, everything is handled by the foundation. Of course, we do home care. Without home care, there is no palliative care. My respects to my guru, my guide and mentor. It's Dr. M.R. Rajagopal on the left side. Many people call him the father of palliative care. I think many of you would have known he has been awarded Padma Shri in the year 2018 for his pioneering work. On the right side, we have Dr. S.V. Satyanarayan Raju, a very renowned orthopedician. done lakhs of orthopedic procedures to help children afflicted with polio to help them walk again. He has been awarded this year, again, Nobel Prize, and we are proud that he is one of our trustees sitting on our board. Dr. Satyanarayan Raju just donated us about 1.5 acres of prime land in the outskirts of Visakhapatnam to build a integrated center for geriatric and palliative care. This will be a non-profit facility. So it will provide services which are not easily available in the existing health systems, like respite care, transitional care. What exactly, what this organization, Athulya, is doing here? Even long-term care and also dementia care. This is still in the making. Hopefully, within the next 24 months, we'll be able to commission these services. I don't consider myself an expert in geriatric medicine or palliative care, but I'm certainly a student of what I've been practicing. I will not go into the statistics. Dr. Karthik has extensively covered what the problem that we're going to face in the coming years and decades. So how geriatric medicine is different from our regular medicine that we practice every day. The presentation is atypical, and the biggest problem about geriatric medicine is multimorbidity. Each and every patient, almost 50% of people who are 65 plus have at least 3 illnesses, and it can be almost 5 illnesses for about 25% of them. So, in a young man, you all know, all the symptoms a person has got point out to one diagnosis. Whereas in geriatrics, you see a fall, see postural hypertension, see syncope, incontinence. If you go on investigating, there can be 3, 4, 5 reasons which could have caused it. So it becomes that much more difficult to pinpoint the reason and to manage it. And even geriatric care is different from our regular medicine in the sense that we are not just looking at the physical aspects of care. Even the social aspects, the economic, the emotional, the social, if I can say, even the spiritual matters also concern these people. So unless we have a holistic approach, the desired outcomes in elderly people cannot be achieved. So the goal of geriatric medicine is generally preservation or restoration of functional ability. After this slide, maybe we'll have some interaction. I would like to learn from you. I would like to take the input from you about some of the very important issues that concern us and concern our patients. So the maintenance, protection, restoration, or even promotion of functional ability is the #1 priority in geriatric care. And this should be done in line with the values and preferences of the people. And all the time, we have to take even the family into consideration. For both geriatric and palliative care, the unity of care is not the patient alone. It's always the patient and the family. Ethics, medical ethics, they're an important constituent of any clinical medicine. When it comes to geriatrics, one important problem that we have, one important challenge that we have is the inability of many of these patients to take appropriate health-related decisions. So sometimes we decide for the patient, And actually we are not infringing his autonomy, because the patient may not be in a position to take appropriate decision. Do we do this or not? Many times we take the decisions on behalf of the patients, keeping their best interests in mind, or at least believing that we have their best interests in mind. But let's just remind ourselves that the patient, he or she has the ultimate power and rights over her body. You may be knowing more than what the patient knows about their health condition. And what you are suggesting may be the best, but at the end, the wishes, the expectations, the values, and the preferences of the patient and their family should get the due recognition. The illness experience, particularly chronic illness, has changed over decades. In the good olden days, people used to pass away relatively at an younger age. So living with chronic illness is not much of a problem. But with the advent of modern medicine, people are living longer. But there is a flip side. People are living longer with ailments, which necessitate a lot of interventions, hospitalizations. The challenge is to protect the quality of life of the patient, keep them functional as long as possible and as well as possible. In chronic illness, we generally look at three different illness trajectories. The one is the rapid and predictable decline. This is what we see in most of the cancers. Functionally, they'll be near normal for quite some time, maybe even while they're undergoing treatment and they're responding to treatment, but at some point of time in the trajectory of illness, the function capacity starts to decline abruptly and ends in death. The period may be about 3 months, 6 months, 9 months, 1 year. These cases are much easier to palliate because the prognosis is predictable and there are enough models available to take care of these people. Look at this. A steady decline with intervening exacerbations of deterioration of function. Most of the time they recover, but you can see that every time they recover, the function status is not coming back to the same state that they used to enjoy before going into that episode. So there is a decline which may not be perceptible by the patient or the family, and suddenly after one of these episodes, maybe during one of these admissions, that happens. But it looks to the family as if it is come all of a sudden. But it's been happening over a period of time. This is what you commonly see in organ failures, maybe liver failure, heart failure, lung failure. The last is, this is a prolonged dwindling. Almost undistinguishable, almost normal. Very slow deterioration of cognition, deterioration of functional facilities. Slowly, he will lose the capacity to meet his IADL, then he cannot even do his normal chores, even activities of daily living cannot be managed on his own. It happens over a very long time. It may span up to 5 to 10 years. And if his care is good, if the medical care is good and the family support is good, it may go even up to 10 to 12 years. Again, prognostication is impossible. You never know how long a patient with Parkinson's will live. You never know how long a patient with Alzheimer's disease will survive. He will not die of Alzheimer's. He will die of respiratory infection, maybe die of lack of nutrition, aspiration. Very, very difficult to palliate. Very difficult for the caregivers, very difficult for the family, because you do not know where you are leading. Maybe I will stop here for a moment. I sincerely wish that there be something that we take away from this meeting, both you and me. So I'd like to know from you, if somebody wants to discuss it. It will be painful, I know. It's not easy to discuss these things. Someone in your family, someone in the neighborhood, one of your friend, maybe your grandfather, grandmother, who went through the chronic illness, who suffered during the course of illness. You were there looking at the whole process. You wanted to do more to help them, but you couldn't do. You don't know how to do it. You do not know what can be done, and where it is done, and who can do that. It can be maybe, as I said, it can be dementia, can be Parkinson's, any neurodegenerative disease. It can be a malignancy. So anybody, any of my doctor friends, anybody sitting in the room wants to share their experience with somebody they know who suffered. In spite of the best intentions, we always think that something could have been done, but we do not know how and where to do it. Please, can somebody give the mic to him?
I'm Dr. Siva Prakash.
Sir.
This was a very inquisitive thing I wanted to understand about. See, there was an old doctor by name Dr. Veerabhadran. He's no more now. My grandmother is 95, alive now. Okay. And around 8 to 9 years back, she had some imbalance. She fainted every time she got up. And so we had to take her to the doctor. It was an accidental positive decision. We took him to Dr. Veerabhadran. And he started evaluating the sodium, potassium, all that. And I don't think many people will know who is the right person to handle such a situation. And I'm lucky that I have my grandmother till she's 95 now. So these sort of situations do happen. So I was always inquisitive, like all the elderly people get that advantage. Maybe the experience of the doctor or something was very favorable to us.
Thank you very much, Dr. Shivakumar. Anybody else? I'm looking for some feedback about health-related suffering which has not been addressed properly. Maybe it is pain, maybe it is breathlessness, maybe it is stress ulcers, maybe somebody couldn't swallow. It's okay. Thank you, anyway. During my 10 years of journey in geriatric and palliative care, I've seen people from all walks of life, very senior doctors who rose to the rank of Director of Medical Education, Head of the Department of Medicine. But when their time came, they passed away like just anybody else, suffering, not getting the treatment that they actually needed. I very well remember a very senior doctor, physician, held the highest position a doctor can hold in the state of Andhra Pradesh. He was 90 years old, immobile on the bed with stress ulcers, and the only person who was taking care of him, I'm not considering the unskilled caregiver who is there with him. His wife was giving him insulin twice a day, and she's almost blind. Just imagine how she can draw insulin and give it to him at that age with very poor vision. And his son is a physician in Chicago. So it doesn't really protect any one of us. I mean, I don't want to disturb the mental peace of all of you, but in the existing health system, none of us are safe. All our education, all our money. So, see, this talk is not about our patients. I request all of you just to put yourself in this place. One of these days, we'll get old. And some of us will need palliative care during some part of our lives. It is certain. I'm sure I will never require the services of an obstetrician or gynecologist. I may or may not need the services of an oncologist in my lifetime. I do not know. I may or may not. But each and every one of us, if we are lucky enough, will get old. The other option, dying young. I don't think any one of us prefers that option, but the other option is getting old. Hardly any other option. And once we are getting old, whether there is a geriatrician around or not, we need geriatric care. Somebody who is sensitized to geriatric care. Even it is the same thing with palliative care. Generally, palliative care is used synonymously with end-of-life care. It is far from truth. Palliative care is not about end-of-life care. End-of-life care is a small, minuscule part of palliative care. And palliative care is not about death. Again, people talk about good death, right? Can death be good? Anybody? Can death be good? I don't think so. It's not either good or bad, but it's about the life that we're talking about. Palliative care is about life. Life before death. Because life happens till the last moment, right? So that is what we're concerned about. Good life. As long as I breathe, I should be comfortable to the extent possible. I should not suffer with pain. I should be talking to my family. They're all relative terms. I'm not saying anything absolutely. So I think we're going a little off the topic. How much time do I have now? Another 10-15 minutes is okay? Sure. So many times we'll come back to the topic. Many times during the chronic illness, this is what happens. Actually, people will not get the care that they want. Which would have benefited them. At the same time, they will get care which they do not want and which will not benefit them. Do you agree? Sometimes, I'm not saying any of these things are universal. I have a disclaimer. Irrespective of what I say during this presentation, we all celebrate, we're all mesmerized by the achievements of modern medicine. We're not talking about that. But if you're talking about the ultimate goal of medicine, whether it is modern or ancient, it is never just about cure of the disease. It is very important. Maybe our prime objective is to correct the correctable, treat the treatable, and cure the disease if possible. But relief of suffering should go hand in hand. It is not a second option. It is as important as curing the disease, which is not always possible, that we all know. So palliative care is not that we are going to change the outcome, but we can certainly change the journey. This is the World Health Organization definition, which I don't want to go. It will take hours to just discuss this definition. But suffice to remember that it is an approach. It is an approach of medicine. And another important thing is, here the unit of care is the patient. It is the patient and the family. Take a case of cancer. Somebody in the family is suffering from cancer. Do you think it is only the patient who is suffering because of the disease? Definitely not. My father passed away with cancer. I remember it even after 25 years. So the disease, the illness experience is shared by the family, spouse, children. parents, everyone. They all are affected by the psychological, social consequences of the disease. So palliative care aims at not only addressing the quality of life of the patient, but also the family. So they're also part of it. Then we are not just looking at the physical pain. It's very, very important that we address the physical aspects of the suffering. Pain, shortness of breath, malodor, fever, loss of appetite, constipation, all are important priority. But it's not sufficient. Somebody has lost a job, somebody has become a dependent, somebody is guilty that the family is spending all their lifetime savings on him. So these are the issues actually considering the patient. So these should be addressed along with addressing the physical symptoms. So you are also talking about the psychosocial aspects and even spiritual care. How come spiritualism come into this? Somebody is a staunch believer in his own faith, and he gets solace from his faith, and now suddenly, I remember a priest in our hospice saying that I have served Lord Krishna all my life, and why Krishna has done this to me? What sin did I do for Lord Krishna to give me this curse? Crisis of faith. It's very important that these things should be addressed. Health-related suffering. I don't think we have enough of time to go into the depths of this. Huge suffering. During death, 25.5 million. Another 35.5 million people, serious health-related suffering. Serious health-related suffering during the course of the life-limiting illness. Dame Cicely Saunders, known as the founder of modern hospice movement, a British nurse, unhappy with doctors, resigned, became a social worker. She realized that she cannot fight with doctors from outside, went to the medical school, became a physician, and established the first hospice, modern hospice, in the suburbs of London, St. Christopher. And she died in the same hospice which she built. Long time ago, palliative care was thought to be only for end-of-life care. So if everything else fails, and the patient, of course, has exhausted his money also, then he will be sent for palliative care. The present integrated concurrent model wants to bring palliative care team right at the beginning, at the time of diagnosis. Not that they have a great role at the time of diagnosis, but they develop rapport, good communications with the patient, and as the disease progresses, if it gets cured, yes, that's the end of it. But if the disease progresses, then their role will go up. And once disease-directed therapy is no longer appropriate, they will completely take over the care. And palliative care doesn't end with the death of the patient. They will continue to visit the patient's family, do bereavement support, to see that the grief doesn't turn into complicated grief. Palliation, if you ask me to just say 3 words about palliative care, it is about symptom relief, which can be easily done by all of us with a little training, clear communications, which are again very important for all of us, and psychosocial support. The prevalence of symptoms, we all know that are very common in advanced cancers, but you'll be surprised to know that the prevalence of symptoms are also high in non-cancer diseases like COPD or end-stage kidney disease. Geriatric palliative care is not a specialty or subspecialty. It only brings together 2 interdisciplinary medical specialties together to integrate them to provide comprehensive care for elderly people who are going through serious illness. So when to start palliative care? Palliative care can start at any time. Any age, any diagnosis, wherever there is suffering, any stage of the disease. Where to provide? Palliative care can be provided at home, in an assisted living facility, in an old age home, in a hospital, in a hospice. So I think this will be the last slide. Last but one slide. Every person concerned with healthcare, whether it is a ward boy, nursing assistant, physiotherapist, pharmacist, nurse, doctor, everyone should be aware about the philosophy of palliative care, the approach, what we call approach. Each and every one of us should be aware of the role of palliative care. And some of us, at least nurses and doctors, should acquire the core competencies that are required to provide basic palliative care to patients within our discipline. And there is always a specialist. Now, I think many of you may be knowing, MD palliative care is available in at least 3 institutions in India, and DM palliative medicine is available in 5 institutes. So the more complicated cases, we'll leave it to the specialists. Advanced care planning is something very important to avoid unnecessary suffering. ICU is not a place to die. This is something I would like to emphasize. ICU is for make people regain, restore. But once we know that the patient is imminently dying, I don't think there is more sin in confining them to ICU. There's a lot of difference between withholding and withdrawal. By withholding futile transactions, you will be making the life of the family much more comfortable and free of guilt. Although legally, there may not be much of difference between withdrawal and withholding care. So these conditions require more specialized palliative care. So this is what I was talking about. We are talking about life before death. We're not interested in death. Palliative care is not interested in death because we live till the last moment. I think this is my favorite. Know all the theories, master all the techniques, but as you touch a human soul, be just another human soul. Thank you very much.